So welcome everyone to this month's Teach Educational Rounds. Here with us today, we have Myra Fahim, who will be presenting on risk assessments with youth and young adults. We are going to begin with our land acknowledgement. KMH is situated on lands that have been occupied by First Nations for millennia. Lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of KMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase Treaty No. 13 of 1805 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. KMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. Now, I encourage everyone to introduce yourself in the chat and let us know which traditional territory you are joining us from today. If you're unsure, you can visit the website there, www.whos.land. I can put the link in the chat. And you're also welcome to let us know one thing that you're doing to learn or improve your commitment to reconciliation. So I will give everyone a couple moments to do that, and I'll put the link in the chat. Is everyone able to hear me okay? Yeah? Okay, if not, I would just check your, I guess you wouldn't be able to hear. Here, I'll put this link in the chat. If you're having audio issues. Thank you, Marina, joining us from Treaty 3. Thank you so much, everyone, for sharing. We'll give everyone else a couple more moments, and then we'll keep going. All right, so feel free to keep sharing in the chat. I am just going to continue on with some housekeeping items. So if you're interested in receiving a letter of completion for this Teach Educational Rounds, please make sure you registered for the webinar and completed the pre-learning assessment. As well, make sure you signed into the webinar using your full first name and last name so we can track your participation. And lastly, please make sure to complete the evaluation and post-learning assessment that will be emailed to you by the end of tomorrow, and you'll have 1 week to complete that. So here's a little bit more information on our presenter today. Myra Fahim received her honors Bachelor of Science from the University of Toronto and a Bachelor of Education from Queen's University. Additionally, she holds a Master's of Science in Psychology and a Master's of Social Work. She is registered with both the Ontario College of Teachers as well as the Ontario College of Social Workers and Social Service Workers. She possesses additional certifications in smoking cessation interventions, applied suicide intervention skills training, and adult online learning. She has worked in the field of nicotine dependence for over 10 years in a variety of roles and is currently a manager within our very own nicotine dependence service. She has a private clinical practice where she largely supports youth and young adult clients with a variety of challenges, including mood and anxiety disorders and substance use. Myra is also a mental health crisis interventions training facilitator. So welcome, Myra. And no disclosures to report on her end. So please note that the content of Teach Educational Rounds is centered on evidence-based guidelines from the following sources. Nonetheless, these materials, as well as the verbal presentation and any discussion, represent only general principles, and they do not remove the need for clinical assessments or treatment plans by healthcare professionals. So please feel welcome to use the chat feature throughout the webinar to post any comments or answer any prompts from the presenter. To do this, you can click on the speech bubble icon in the control panel at the bottom. And please ensure you select everyone so that all panelists, hosts, and attendees can read and respond to your comments. You're also welcome to use the reaction feature. So if you want to send a smiley or a thumbs up at any point, you're welcome to do that. And with that, I will hand it off to Myra to take it away. Thank you, everyone, and enjoy the webinar.
Thank you, Natalie. Welcome, everybody. I've been intently reading the chat and seeing some of the steps that folks have been taking to increase their knowledge and understanding. So I really appreciate learning more about what everyone's doing, and thank you, Natalie, for going through the land acknowledgement. Okay, so today we are going to be talking about a heavy topic. Talking about risk assessments, and you probably have already seen the learning objectives. So we're going to be talking a lot about suicide, non-suicidal self-injury. So a heavy topic. If it becomes too heavy, at any time, you're welcome to step away. Know that you're going to be getting the slides anyway. You can always review after. We will be using the terminology, speaking directly about risk assessments related to suicide and non-suicidal self-injury. So there will be a lot of talk about it. So I just want to give everybody that heads up. But again, no worries if you need to step away, you will get the slides. The learning objectives for today. So we're going to very briefly look at the current context of suicide in Canada. We won't spend too much time on that. Those are kind of facts, statistics you can look at with a little bit more detail when you get the slides. We're going to dive into the differences between suicidal behaviors and non-suicidal self-injury behaviors. And then we're going to touch on how to assess and address risk for both suicidal and non-suicidal self-injury behaviors. These are huge topics. We could spend a week talking about each one separately. So know that what we're going to talk about is just going to scratch the surface. I think really my goal is to just provide you with some preliminary tools and ways to think about how to engage in these topics when working with youth and young adults. And then there's just with kind of practice and more learning, you can kind of get more comfortable with it. But we only have an hour, so I'm going to try to cram in as much as I can during this time. So we'll jump right into it. These graphics, the link for it will be on the next slide. You can find it. It's on the government website. But as you look at these statistics, I'm just going to hone in on a few of them. The ones particular to the topic today are really around, if you look at the death rates by suicide, even though the highest proportion of deaths by suicide are amongst 45 to 59-year-olds, it's still the second leading cause of death amongst youth and young adults. And if you flip to the second table, or the bar graph here, you can actually see that hospitalizations related to self-inflicted injury are highest amongst youth. So we're going to talk about suicide, but a big thing that's coming up and challenging a lot of clinicians is this self-injury, non-suicidal self-injury behavior. This is becoming a really big thing. And unfortunately, it is quite prevalent. So we do want to arm ourselves with the skills and the comfort to be able to talk about these with clients so that we can help and support these behaviors that are becoming a bit more prominent. Suicide thoughts, plans, and attempts. Again, more statistics. We do want to kind of look at the fact that 4% of individuals aged 15 years and older, this is Canada-wide, 4% will report having a suicide plan. But when you look at the way that breaks down, those in the lowest income quintile have higher rates. So these kind of speak to some of those risks that we'll touch on a little bit next, risks that may make someone a bit more high risk for suicidal ideation, suicide attempt. It's, even though the percentages overall kind of feel really small, they're actually really big when you think about it in the grand scheme of the entire Canadian population. This is an issue, a big campaign for CAMH as well. And it is important to talk about. And the more we understand these statistics and the more we talk about them, the more we destigmatize, the more we can make it something that it's okay to talk about and it's okay to get support and help with. And it's not still, we are making headways, but it's still something that people are really hesitant to talk about. So the more we understand, the better off we all are in terms of being able to engage in supports for individuals who need it. So some additional risk considerations. This is not a complete list by any means. There are actually a lot of different risk factors that may make someone a bit more higher risk for suicide-related behaviors. Just honing in on a few: 2S LGBTQ plus youth almost triple the rate of their non-2S LGBTQ plus peers. Indigenous youth, so First Nations, Métis, and Inuit youth have 3, 2, and 9 times the national rate. This is a serious, big risk factor, and it points to a very big issue. Things that we've talked about, that we acknowledge, that lots of the intergenerational trauma, lots of factors to consider, but we do know that those are big risk factors, and we want to make sure that we create the opportunities for support for individuals who are more at higher risk. Those of you who are familiar with the very big famous ACE study, so the adverse childhood experiences, those studies have shown that individuals who have 4 or more of those ACEs are 30 times higher compared to those with no ACEs. And having any of those adverse childhood experiences makes someone at an increased risk for suicide. And we are the nicotine dependent service. It's really important to note that their studies have shown that there is an association between smoking and an increased risk of suicide. There has been no causal link established at this point in time, but we do know substance use in general is a risk factor. Substance use is often a means to cope, and understanding the reasons for coping and what a person's dealing with can help us in terms of our interventions. But substance use is a risk factor, especially active substance abuse can be a huge factor in someone if they're in an can be a huge factor for someone if they're in an active attempt, because judgment could be impaired, etc. So it's really important to understand the full spectrum of substance use, including smoking, which is why it should be considered part of prevention and intervention programs. Often it's not listed as part of substances that we should be screening for. So it's really important that it's embedded as part of our programs. Definitions, I'm going to hone in on just a couple here. Died by suicide is the term that we want to use when referring to individuals who have died by suicide. So it is a suicide that ends in death. I'm sure we've all heard the use of committed suicide or even completed suicide, which was the kind of the switch over in terminology from committed. It switched to completed. But really, we're trying to move away from judgment-based terminology around suicide. We don't use those terms when referring to any other type of death. There's no reason why we should be referring to someone who's died by suicide in a different way than someone who's passed away from any other illness. So we want to make sure we're using kind of consistent terminology. And this is the breaking down the barriers between this separation that we constantly have between physical health and mental health. All the terminology where we're trying to kind of normalize the discussion. How someone died is a fact. There doesn't need to be any presence of judgment-based terminology in there. Jeff, yes, there is a standard definition of what's considered an ACE. When we do an activity a little bit later, I'll pull up the link for the ACE study. And you'll be able to kind of dig into that. It's a really useful tool when dealing with trauma and understanding, past experiences and risks, not just for suicide, but for a whole host of things. Non-suicidal self-injury, so that is different. That's the deliberate injury that one does to their own body with the absence of intent to die. Someone who self-injures is not attempting to end their life. They are trying to cope. The most common reason is regulating their emotions. So either they're trying to, they're feeling an intense emotion and they're trying to distract away from it, or they're not feeling anything and they're trying to feel something. But it's a coping mechanism. And actually, a client of mine referred to her own self-harm as just an unhelpful coping strategy. She recognized it wasn't helpful for her, but she knew that it was something she was using to help her cope with the anxiety that she was dealing with. Okay, so some distinctions between suicide and non-suicidal self-injury. Again, really the purpose of suicidal behaviors is something final. We're trying to permanently escape the pain. It says frequency, rarely frequently repeated. You rarely have individuals who've attempted, 10, 20 times. It's something that's final. Someone's really trying to end their pain. And the pain is persistent. If they've made an attempt, their mood often remains the same or worse. And we know that in terms of restriction of their means, so if someone, say, for example, intends on overdosing with medications that they have, we know that removing that means can be effective in reducing their risk. On the other hand, with non-suicidal self-injury, someone's using those behaviors as a coping mechanism. So it's typically not lethal means. They're trying to bring relief. So they're experiencing pain, but they can interrupt that pain with the behavior. They still have some hope. They're not kind of in this really hopeless, helpless, there's nothing that I can do. The self-injury is actually a means to be able to cope with life. They want to be able to cope with life. And post self-injury, someone may feel, whether only brief, may feel relief from their distress. And we know that trying to just say remove the means isn't really effective in terms of reducing the behavior because it's a coping mechanism. They're going to find some other way to get the means to help cope. So that's a really important factor that we'll talk about a little bit later in terms of addressing self-injury with clients. Okay, so focusing on suicide first. There are many different assessment tools depending on the organization you work for. You may have certain ones that you need to use. And in the resources I have at the end of the slide, there's actually a toolkit that lays out all the different types of tools for risk assessment, and you can see what the different ones assess and what are appropriate for youth and young adults, etc. But really what we're trying to assess is desire, capability, intent, and any protective factors. Getting a picture of all of these things will help us assess whether someone is at risk, low, moderate, high risk, whether it's an imminent risk or something active going on. So desire is really someone's, how intensely someone wants to end their own life. So this is where we would assess hopelessness, helplessness. How frequently are those thoughts coming? How intense are they? Can they kind of move past them, or is it an intensive, I can't do anything else because this is all my mind can think about? Capability. So what suggests that someone would be able to follow through on this desire? So this is where you kind of assess those risk factors. Past history of attempts or exposure to, so someone around them in their network may have died by suicide, access to means, substance abuse, which I mentioned earlier, unmanaged mental illness, extreme emotional dysregulation. These are all risk factors. These are all things that may make someone more likely to be capable of following through on a plan. And that kind of brings us to intent, which is the actions that indicate someone will follow through on their thoughts and their desire to end their life. So this is where we're going to look at do they have a plan? How specific is that plan? The more detail that individual has, the way higher the risk. And is there a time frame? we know that that 72 hours, even when we're safety planning from that point in time within the next 72 hours, that's kind of the highest risk period. That's really what we want to ensure a person can keep themselves safe from. So anyone who has a plan within the next 72 hours, much higher risk. Preparatory behaviors, giving away items, goodbyes, withdrawing, all of those things would suggest that someone is kind of preparing themselves to follow through. On the flip side, we have our protective factors. These are the things that might sway a person away from following through on those actions. So those connections, those meaningful things in that individual's life that might tie them to wanting to stay here, wanting to have hope. So social supports, future planning. Do they have goals? Are they, in cases of youth, are they applying to post-secondary education? Are they applying for jobs? These things suggest that a person intends on being here to be able to follow through on those things. Core beliefs and values, a sense of purpose, whether through religion or spirituality. These are all buffers, things that help potentially lower someone's risk, and also are important in when we're addressing suicidality with an individual, kind of really honing in on those factors. Protective factors are important in terms of trying to de-escalate a situation and create a safety plan. Okay, so here's our little activity. It's important to recognize that depending on our level of experience in dealing with suicide and talking about suicide with clients or with even folks in our lives, we may rate risk differently. And I think the important thing is that we want to be able to assess all the factors, and given what we know and understand of that individual, make a decision as to how at risk is this individual. So I want all of you to take a moment and go through. So we have Leonard here, who's 17 years old, a high school student, and here it's not all the information, and sometimes we don't get all of the information, and we have to just make the best decision we can with the information we're able to get. But here's some information we gathered based on desire, capability, intent, and buffers. So I would take a moment and just assess where you would rank each individual on each individual risk component, and then what the overall risk would be. So I'll give you a moment to do that, and then I'll share kind of where I would place this individual. We have two different individuals we'll go through, and then we'll talk about how we would act on that. And I have a little bit of a story to share, which we'll do after this activity. So if you want to take a moment, and Jeff, I'm going to find you that ACE study. And you don't have to, so Fraser, you can say what your overall score is. You don't necessarily have to list each individual one. So we have moderate, moderate, low, okay, so mostly moderate, we have a high, okay, a couple of high, mostly moderate, some lows. So I'm going to jump ahead. Jeff, the link may have gotten a bit buried from the responses. You can scroll up and get it. It's not the link to the actual study. I just kind of pulled up the first legitimate site that came up in my Google search, but it's the CDC Kaiser study. Okay. So here are my thoughts. Desire, we know someone's feeling hopeless, has daily thoughts. That's going to be a bit on the moderate to higher end. From a capability perspective, there's no history, no access to the means. There is a diagnosis of depression, but it's being treated. So it's not an unmanaged mental illness. There is daily substance use. So now we're thinking moderate. If there was no substance use, it might be a bit lower. There isn't some intent. There's plans to use a firearm, no other detail, not when, not where, not any of those, no time frame. So again, because there's some plan, a bit higher, but not really, really high. This is now just based on my experience. We're all going to have different thoughts on how we would assess risk. Buffers. So attends weekly therapy, lives with both parents and a younger sibling has applied for post-secondary programs. So from that perspective, this individual is future oriented. They've now thought about what they want to do. They make their weekly therapy. That's huge, especially with younger clients. Like, coming to therapy on time every week is a big thing. So that I would rank lower. So overall, I would say I would rank this individual as low to moderate. We'll talk about what that means a little bit after. So we'll go to the next one. So here we have Sarah, 15 years old, a high school student. And here are the information we've gathered. Again, you don't have all of the information, but based on what we have, how would folks kind of rank the overall risk for Sarah, given the information we have? Hi, hi. So we're getting these responses a lot faster. This one feels like a bit more of a clear-cut one, not a bit kind of, high on some, low on others. This is kind of high, high, high across the board. Our red flags would be going up if we're hearing this. Okay. I felt the same way. This person has a lot going on and is really struggling. And so we want to make sure that this person can be safe. We know that they're not actively engaging in a suicide attempt at that moment. But it looks like this individual is ready to follow through. Okay, so what do we do? And this, again, we could talk about this for a week, but I'm just going to give you some kind of tips and tools. So these are the kind of different levels. So, if an attempt is in progress or someone has initiated, we're taking immediate action. There's no discussion. We are being directive and we're taking immediate action. We're letting the person know that we're taking that action. We're following through on our actions to support that individual. Imminent risk, again, we want to remove the imminent risk. So this is someone who's planning to and about to make an attempt. So we want to disable the plan, remove the means. So if someone has the medications in their hand, we want to work with them to get them to move it to the next room. Or if there's a firearm in the room, we want them to move to a different room. We want to get them away from the means. We know that that's effective. And then we want to disable that plan, try to work with that individual and facilitate an emergency response if needed. If we cannot disable the plan, if we cannot move that person away from the means, now that becomes even more imminent. Emergency services need to be involved. I put high/moderate risk, doesn't mean they're the same thing, but the response to it would be similar, which is we want to de-escalate. We want to validate the pain that someone's living with. We want to listen. Often we get scared. We worry about the responsibility that we take on when we hear that someone's struggling. We worry about, what if we say the wrong thing? What if we do the wrong thing? What are the consequences? And they can feel like they are pretty high consequences. But taking the time to listen and to be there and to validate the fact that the person's talking to you is a good thing. The fact that they're able to sit there and talk to you is the thing that we want to hang on to. We want to find those buffers. We want to safety plan. And the safety plan is to keep them safe for the next 72 hours, not forever. There's no person that's going to commit to it forever. But what they can commit to is in the short period. What can we do to make sure you stay safe and connect you with supports in the next 72 hours? And, oh, yes. Thanks, Jeff, for copying in that. So those are the kind of the ACEs, and there's a questionnaire you can do to determine how many ACEs an individual kind of ranks with. And so jumping to low risk, again, we want to validate always. And I mean, this is just part of clinical work. We want to validate, we want to listen, we want to explore options, because someone who has low risk may be seeing options in their life. So we want to hang on to that. Oh, Julia, great question. So I'll answer that in just a sec. And we want to identify those buffers, meet the person where they're at. A big thing, avoid superficial reassurances. And often when we are scared, we want to just make everything okay. So we want to avoid saying the words. We want to avoid we worry that if we say this, if we say that, a person wants to end their life with a gun, if we say it, that we might do something. But the more we can talk about it in an honest way with the individual, the more they feel that they can open up about it, as opposed to hiding how they feel and their behavior. And we want to, sit with them with their emotions. You don't want to, with a person feeling just overwhelmed, we don't want to throw a bunch of advice at them. We want to be really specific, and we really want to hear them and reflect that back, really using those reflection skills. And so, Julia, doing this over, a phone is really hard, because you can't use your mental status, all the factors for, say, a mental status exam, where you can see how a person's doing. But this is where you need to rely on really asking a lot of really specific questions about where they are, what are they doing. And I would say, if you're not sure, err on the side of caution. We always want to do that. So you can't see a person, but you can hear tone, you can hear silences, you can try to listen for background noises. You can ask those questions, have them describe to you where they are and what they're doing. You have to rely more on those specific questions than if you were in the same room as a person. And it may be that this is the way of the future, right? We may be doing virtual calls mostly, or phone calls, and not able to be there, but we can still provide that empathy. We can still provide that support and ask those important questions, because that, intent, capability, and all those 4 factors, those are things that we can get answers to even over the phone. We just may need to ask more specific questions. I know that's really vague, Julia. Hopefully that answers something. Absolutely. But more often than not, you may not be in the same physical space, right? A person may be calling you urgently. Like if you're seeing clients, you may get an urgent call, or, you may not be necessarily with someone in an imminent situation. You may be with someone in session who's high risk, but not imminent. So then we're really trying to talk to them about how to support and creating that safety plan. And even if someone's low risk, but they've been high risk, always reviewing that safety plan is really important. So that's a great question about warning. As a clinician, there may be no warning. You don't see a client all the time. As a person, say, if it's someone who lives in the same household, there may be warnings. There may not be. We know things like preparatory behaviors. So if you see someone starting to give away their belongings, and you know they've been struggling, then that might be that would be a red flag. Oftentimes we actually hear that someone who's been struggling with a very low mood, before they attempt or die by suicide, that their mood improves slightly. Often that, folks have kind of described that as feeling relief, because they've made a decision and they're no longer struggling with whether they should or shouldn't. So warning signs, they vary by individual. And often I say, if you know a person, where have they moved from their baseline? And that will tell you whether there's something to be concerned about or not. If a person kind of generally struggles with low mood, but that they, nothing's changed, and they're talking to you in the same way, they're planning for the future, all of that, you wouldn't necessarily be as worried as someone who's perhaps has a low mood and they dropped out of their program. They, gave their dog away to a family friend. They, are starting to do things that suggest that they don't intend on being around. It's really hard. And I think it's really easy for those who've been around folks who've died by suicide to say, no, we didn't know. What should we have been paying attention to? And it's hard. And there's no right or wrong or specific answer key. All we know is that the best we can do is keep having these conversations, be prepared and be comfortable. And comfortable is probably not the right word to use, because I don't think anyone's ever comfortable talking about these things, but we can be willing to. We can push down that discomfort and step in that vulnerability to be able to engage in those conversations, knowing that they're scary, but knowing that engaging in them is actually helpful. And the more we normalize the discussions around it, the better overall some of those statistics we showed earlier will become over time. So yeah, I know it's not helpful to say sometimes there may be a warning sign, sometimes not. But paying attention and talking about it. When you notice something feels off and that your gut's telling you something feels off, to ask about it. And those clients who are generally high risk or have a lot of risk factors, screening for suicidality and risk all the time. So I have my clients who are higher risk, we screen every time I see them. It's one of the first things we talk about. They know it's part of our routine, just because that's what we want to do. We want to establish where they are at. Has their risk gone up? Has it gone down? If it's gone down, why? If it's gone up, why? And trying to really dig down so that we kind of always know what that baseline is and can kind of understand when it's shifted from it. So the great comment, which brings me to the story I want to share about a client. I'll be quick because I know we still have a few more slides to go. I was working with a 17-year-old who has had a history of 2 prior hospitalizations due to suicidality. And the first hospitalization was a lengthy one. The client overdosed and was found, thankfully, and brought to hospital. So she was in hospital for a while. The second hospitalization was not actually due to an active attempt. She was working with a therapist at the time, and she shared with the therapist what some of her thoughts around suicide are, and some fantasies around suicide that she's had, things that she kind of thinks about how she would do it, and they're graphic. After that session finished, the therapist called that client's parents, told them, and that those clients' parents called emergency services, and she was taken to hospital, informed. She was only in hospital for a brief time, and she shared the details of her thoughts and kind of this plan that she had, but really had no intent. And this is where the importance of assessing all factors. A person may be really high risk on some, but lower risk on others. And this is why the full picture is important. So this individual wasn't planning on following through, and which is why she was kind of formed and then released. But that kind of broke her trust with the therapist. She completely disengaged after. So here I am working with her. She's always kind of said to me, I don't have a plan. I can only take what she gives me. She said it firmly with me. She says, I don't have a plan. I think about it all the time, but it's not specific. And we talked about the limits of confidentiality. She's very familiar with the system. And I remind her, everything you say is confidential. The same thing that we all go through when we're working with clients, in situations where you're at risk or those around you are at risk, confidentiality has to be breached, because it's my job to keep you safe and to keep others safe when we're working together. What I do tell my clients, especially young clients, I tell them, here's what I would do. In the event that we have to break that, in the event of these exceptions to confidentiality, I would notify you as best as I can. I would tell you first, and I would try to work with you to do it yourself. So if I'm working with a client who is high risk, my preference is to work with the individual to call 911 or emergency services first, and then have them work with them. We want to empower the individual to do it themselves. If a client is refusing, then I would tell them, I would be directed and say, this is what I'm going to do, and tell them I'm going to do it, and then do it. We may not always have that opportunity, but when we do, informing the individual is important, and it's even more so important with younger clients. These are individuals who most of their life are being told what to do. They have very little, if any, autonomy in their life. People are telling them what to do. They take decisions out of their hands. When they do make their own decisions, they're often told, no, that's not the right decision. So if we can empower the individual to take the steps themselves, they're more likely to do it. And they're more likely to stay engaged, even if you have to make that exception to confidentiality. So yeah, we can ruin rapport with clients, but remember that Just because we're going to make that exception to confidentiality doesn't mean the client doesn't need to know about it. We should tell them. If we are able to, there is a benefit to telling them, because then they know, and then they have the opportunity to take the action themselves as opposed to us taking it away from them. Take the action of engaging in emergency support services. So talking with the client, I had a gut feeling that she wasn't giving me the whole picture, and it took some time. And I knew that she had bad experiences with what she describes as bad experiences with previous therapists and her previous hospitalizations. And I reminded her, this is my process. What you share with me, I look at the whole picture. We're going to go through everything. You know how we assess for risk. I want you to feel comfortable, and I'm trying to show her that I'm comfortable talking about, again, comfortable isn't always the right word to use. I'm here and I'm ready and willing to have this conversation with her. Eventually, she was able to kind of share the details of some of those graphic thoughts that she had. Yes, it was graphic. Yes, it was scary to hear. But I also know she lives with family who keep a very supportive eye on her. They're involved. She comes to therapy every week. This is a 17-year-old, applied for school, knows what she wants to do, showed up to therapy. She was the first person in the virtual room every time, and I show up on time. And when she missed it, she gave me a heads up always. So I knew that this individual was committed. There were things that she wanted to do. So it was graphic and it was scary, and I got worried. And when I finished the call, I was still worried. But I also reminded myself I need to look at the whole picture and keep that bond with the client, keep that therapeutic relationship is important, even if we have to breach that confidentiality. A senior that will let you know. So, you know what? I don't work a lot with seniors. I mean, in this situation, they are in isolation. So as a clinician, I would try to see how can we connect this individual with supports. Can it be a service that checks in on them, especially with virtual services? If an individual doesn't know technology, isn't comfortable with technology, what can we do? Can it be phone? Trying to connect this individual, because that isolation is really a big thing for older individuals. I know that's not entirely helpful, but I think really trying to figure out how can we establish supports so a person can feel connected. And honestly, I used to volunteer at the Toronto Distress Centers. A lot of the phone calls we got were from older individuals who were isolated. So even just trying to encourage them you can call those lines. If you're feeling really worried and isolated, call a crisis line. You can engage in a conversation. We won't be able to talk to them for a long time, but we are able to be there and provide some support for individuals. Oh, what's the best way to communicate that? So I would say to a client, I'm concerned about your safety. You've shared with me X, Y, and Z, and you are telling me that this is something that you intend on following through. As my job, as we've discussed, is that if I'm worried about your safety, I'm going to need to tell somebody. However, I think it would be really helpful. Why don't we do it together? If I'm in the same space as a person, or say, is it possible for you to get on a different phone and call emergency services? I'll stay here with you. It's better if you do it. Trying to remind them, this is, I want to respect your autonomy. Can you please make that call? Do you want to make that call? How about we do it? Trying to encourage them to do it, or together. And then if they say, no, I'm not calling anybody. No, don't tell me what to do. I don't want to call anybody. They might raise their voice, and you say, okay, so as I mentioned, it's my job to ensure your safety. I'm concerned about your safety, so I am going to make a phone call to emergency services and let them know where you are, and someone is going to be responding, and you just be directive. So it depends on the risk. If a person's high risk, I check in every time I see them. If a person's low risk, I always kind of ask general questions about how they're doing, and if I sense that someone's kind of gone from their baseline, then I would check. I think there's nothing that you're not going to do harm by checking in about it. And if a person's not having those thoughts and isn't high risk, they'll shut it down fast. They'll be like, no, I'm feeling upset, but no, I'm not thinking about it. I'm not going to follow through. That's not where I'm at. And okay, I just want to make sure, and then you move on. The person will be quick to tell you if that's not where they're at, and that's okay. Great that they're feeling great. Great that they're not feeling, they're feeling better than where they were before. And then we move on. So, what's been helping? Tell me a bit more. Last time you were feeling really low, and this time you seem to be feeling a bit better. What's been helping? Okay. I'm going to try to run through the next part is about the self-injury. I know that there's so many nuances to all of this that we can, again, talk for a week about it. Okay, so assessing non-suicidal self-injury. So self-harm, we kind of talked about those clinical distinctions. It's quite different. We know it can lead to suicide and is a risk factor. Why? Because someone who's using that method to cope with something is dealing with pretty strong emotions, likely dealing with pretty strong emotions, and they may move from this is a coping mechanism that's working to this is no longer working for me. Also, some of the ways that someone self-harms could be a really high risk. If someone's cutting and they cut the wrong way, that could be really high risk. And you saw that hospitalization chart, right? There are individuals who are self-harming and getting hospitalized. So that could also be really dangerous too. So when we're assessing that self-injury, we want to understand, when did it start? How long has it been going on for? How are you doing it? How often and where? Where on your body? How damaged is the skin? How, have they caused any permanent injury to themselves? What kind of issues are going on? Are there self-esteem issues, body image issues? What triggers the behavior? What is the behavior trying to do? What is the intent of the behavior? And what's the consequence of engaging in that behavior? And when we discuss this and we want to work with the client, we are moving away from trying to address the behavior, because we know trying to remove that means and not focusing on why is not going to be helpful. So we want to focus on what is that trigger, what's causing the distress that leads you to engage in what you feel is a helpful coping mechanism. Whether it's healthy, whether it's harmful or not, doesn't change the fact that to that individual, this is a helpful behavior. And being able to acknowledge and validate that for an individual makes them more comfortable to talk to you about it. If they feel like they are being judged by utilizing that coping mechanism, they will shut down. They will not engage in a conversation with you about it, and you will not get those details that then might help you with some harm reduction, that then may help you to talk about alternate behaviors down the line once you've talked about the why. Okay, so I will say, and this is not going to be a helpful statement, you can never be certain. You can absolutely never be certain that a person, when they leave your office or hang up the phone, that they're not going to follow through on something. You can never be certain, and that's what makes it so scary sometimes. All you know is you can only go off of what they say to you. You can only go off of the questions you ask and the judgment you use to make an assessment. And if you're ever unsure, you err on the side of caution. We want to understand all of the factors. What are the things that pull them towards suicide, and what are the things that can pull them away from? And we want to engage in those buffers. So if you're still concerned, even though a person says no, 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 then spend some of that time talking about those buffers. So, what have you been doing? What have your friends been doing? What's been, how has school been going? And try to talk about the things, those protective factors, to engage with the individual and assess, like, are they making plans for next week? Because really, we're only calling 911 if someone's going to follow through within those next 72 hours. If someone says that they're going to, they're thinking about it, we want to move them away from it. But emergency services are when there's an imminent emergency. I'm not saying high risk means you just let it go, but when it's high risk, we kind of want to disarm the plan and move them towards safety. But 911 is really when there's an imminent risk. And if you're worried, then suggest, and you're able to see a client sooner, see the client sooner just to check in, or do a phone check-in. Say, you know what, you say you're doing okay. How about we just do a quick 10-minute phone check-in later this week, just to make sure you're still feeling okay there then, and do that check-in. But you'll never be certain, unfortunately. It's one of the hardest parts of the job. You just don't know, right? Okay, quick case study. Okay, we have Mia here, 18-year-old female. So I went through kind of the things that you need to assess. So has been engaging in self-harming behavior for the last 3 years, is cutting using razor blades and occasionally reopening the same wounds that have healed. 3 to 4 times per week at home in the bedroom, generally on the inner and upper thighs, occasionally on the forearm, and there's significant scarring that you can observe. This individual has issues with weight, engages in disordered eating behaviors, lives with significant social anxiety, passive chronic suicidal ideation, triggers, again, that social anxiety, so classrooms, being around peers when the attention's on her. Her mother's a huge trigger because her mother is working with her, is pressuring around that kind of body image issues. And just meal times, right? Anything that has to do with food. The intent is help to gain a sense of control, the strong emotions. The emotions feel strong. That cutting behavior is control because I do it when I want to, and I do it and I know what it's going to feel like and I know what I'm going to do. And it just kind of distracts away from everything going on. Now, the consequence, inflamed and infected wounds because it's not good wound care. And she really doesn't like that people can see scars on her arms, and she gets what she describes as judgmental looks. Okay, so Emily, so folks, while you just think about all those factors, I'm just going to flip to the questions and then I'll flip back to this case study so you can look at all the facts here. But this is just a quick thing. So what are the biggest risks for Mia? What information do you feel like is missing, if any? And what would be one of your first steps once you hear all of this information? So, right, so I'm going to put it in the chat. So risks, additional info, and first steps. So I'm going to flip back so you can get all of the information and you can just throw it in the chat. Okay, so, and Emily, while folks are thinking if your minds can do two things at once, how do you work with clients who only have you as their support? We try to find other supports because a client, as you know, especially depending on the organization you work for, or if you're kind of doing private, you're kind of limited, right? You can't see a client every day. So you connect the client with resources, and you come up with, if you can't get a hold of me, who are you going to get a hold of? Maybe they don't have family, but there are resources, which you'll see in my slides at the end, really trying to engage them in supports and making sure that they understand where those resources are at. And if they're resistant to resources, I'll try to understand why, because often youth are resistant to resources because they don't want yet another really annoying thing to read that people just keep throwing paper and information at them. I find with clients, they just like, I don't want a pamphlet. Don't give me a pamphlet. It's not helpful. So the resources that I have, there are some youth-led websites that you can go to that may actually resonate with an individual a bit more, and they may be more likely to look at those resources and maybe suggest in session, hey, why don't we just look at them together and see what you like, see if it's helpful to you, and engage with them that way. Maybe doing it together might kind of break the ice around it a little bit. Okay, so what are we looking at? Triggers, risks. Yes, the wound reopening, risks, infection. Infection is a big thing because that can be huge, very problematic. No post-secondary plan, risk. This person doesn't really have kind of plans or engaging in future-oriented thinking, for as a way to say it. The triggers are a lot. Lack of supports from mother, issues with body image, and we know disordered eating behaviors and body image issues are some of the hardest things to deal with, really and truly. So that is a really big thing to tackle. Additional information, assess thoughts of suicide. We know that there's some chronic suicidality, but it's passive, but we still want to understand more. Does she have a plan? Do those plans come up with those passive thoughts? Lack of support from family, already body conscious. So yeah, having the scars kind of exacerbate that a little bit. Missing information, addressing feelings. Yes. Zainab, the heavy cuts, so the cutting and the location of them, especially forearms, we really want to understand. So we may do some harm reduction around wound care. In the meantime, while we're trying to address things, how can we make sure that if she's engaging in the behavior, that she's doing it in a way that prevents infection, and she's doing it in a way that prevents any deep wounds, for example. So lots and lots of thoughts here. This is great. I'm going to flip forward. So additional information. We definitely don't have enough information for Mia right now. We have enough to say we need to look at this further. Counseling, therapy, such an important question to ask in general, but I find it really helpful with youth. Have you engaged in therapy before? Have you engaged in any type of therapeutic support? What's helpful and what's not helpful? Because youth, I find, will be really clear about like what did not work. And you can avoid that, hopefully, so that you can kind of build that relationship with the individual. And we don't have much of the protective factors, I agree. So we want to get that information. Okay, so the first steps with Mia, I'm going to flip through because I'm going to give some of my thoughts. We want to engage and validate. Discussing the behavior directly will help remove any shame or secrecy around it. Discussing it directly and validating. This is helpful to you. You have been engaging in this for 3 years because there's benefit. There's a pros and maybe this is where we do pros and cons. This has been working, and I think it's not, it's not problematic to acknowledge that it's helping her. Is it what we want? Is it dangerous? Does it have consequences? Absolutely. But that doesn't change the fact that it's there. It does provide a function. And if we avoid acknowledging that, then we'll just be, again, another judgmental adult in their life telling them not to do something. So we want to remove that secrecy. Let's talk about it. Let's talk about the details of it. Let's really get a good understanding of what its function is. And we want to focus on decreasing those behaviors by analyzing those triggers, understanding what triggers it and the consequences, because the consequences ultimately may be the thing that helps your work with the client to have them try alternate behaviors. And you know what? I've had clients try alternate behaviors and say, it's just not as helpful. Yeah, did it do some help? It did help me a bit, but I was still anxious after. It's not as helpful. And I think it's okay to also acknowledge that while you're trying alternate behaviors, they may not feel as helpful because you know what's helpful. Let's keep trying. Let's work through that. Let's talk through that, right? I think it's okay to also admit that there may not be an exact replacement, because I imagine this individual has probably tried a few things before they've been here, and this is the thing that's working. And again, as I mentioned, important to engage in any harm reduction discussions if necessary, depending on the type of behavior, and then work around those coping skills, or especially around emotional regulation, because that's often where the self-harm behavior comes from. Yes, the cycle of anxiety, absolutely. Yeah, so it could be avoiding feelings, trying to feel things. It could be trying to like distract. There's just so many different ways, but oftentimes it boils down to regulating the emotions. There's something that we're trying to manage with our emotions, and we're using that self-harm or that self-injury to do so. Okay, so these resources here are actually just from the Government of Canada's website. So these are like Canada-wide resources. Depending on the area you work in, there are always local resources. So I really encourage you to, and you can go through that suicideprevention.ca website. I think that they actually list some local resources there. So be familiar with your local resources, and be familiar with, especially if you're doing virtual care, where those resources are local to that individual. So Zainab, we don't want to encourage kind of replacing harm from one area to another. We want to, I mean, we can, if the client suggests that and says, well, I bleed less here, you can work with them around that from a harm reduction perspective, but we don't necessarily need to suggest that, at least from my experience. We want to work towards kind of decreasing it, not necessarily shifting it, especially if they're doing something that they're comfortable and familiar with. It might be a little bit less risky than trying something new. Okay. I talk to the youth, Danya. I would talk to the individual if you're able to, and try to connect them with some supports. I would not notify a parent without letting the client know first, letting that individual know first. You know the limits of confidentiality. If you're worried about their safety, then tell them, I'm going to have to if you don't. But encourage the individual to tell their parents, encourage the individual to ask for help, ask for support. They don't have to share the details. They can even just ask for support from their parents, but I wouldn't go behind if you can avoid it, avoid going behind an individual. It'll just break the trust, and it's hard to come back from that with an individual. Sometimes we have to, and there's situations where we can't help it, but if we can help it, we should. Yeah, connection to supports. Okay, these are some of the youth-led websites, and just some resources that would be helpful to clients. And then here, resources for healthcare providers. This is the toolkit I was talking about earlier that lists like all the risk assessments and tells you what each one tries to capture. So if, say, you're doing private practice or your organization doesn't have a specific one, you can find one that works for you, or you can just ask questions on those 4 things. You don't necessarily need to use a specific tool as long as you're getting the information or following what your organization suggests for you. Okay, I've taken an extra minute of your time. I appreciate it. Hopefully, I know I may not have answered all the questions the question slide. So hopefully we got some of the questions along the way. My email is here. Oh yeah, there. If anyone has any questions, I'm currently on parental leave, but if you have any questions, you can still send it my way. You can also send it to Natalie. I'm happy to answer or point to some resources. The only thing I'll add on top of all of this is have the conversations, practice having the conversations, to sit down with other clinicians and talk, use the words, practice using the words until they come out without hesitation. Because some of us still hesitate to use the words. So keep saying it over and over and over again until you don't hesitate before you say it. Because the more we can be really clear about it, the better we'll all be. And the more helpful it will be for those who really need the help.
Yeah,
Okay.
well, thank you so much, Myra, for guiding us through such a heavy but extremely important conversation. I know I learned a lot myself, and from what I can see in the chat, everyone else did as well. I know we're out of time, so if anyone needs to head out, feel free to do so. I'm just going to go through some housekeeping slides again. Just a reminder that we will be sending out the slides as well as the recording to you all this afternoon. And then another reminder to complete the evaluation and post-learning assessment that will be emailed to you by the end of tomorrow to receive your letter of completion. And as well, just a heads up about our upcoming Teach educational rounds on August 24th on the topic of tobacco and vaping cessation interventions with the 2SL LGBTQ+ community. So stay tuned for registration opening up in a couple of weeks for that. And then last but not least, as always, feel free to check out our archive list on our website if you want to view this webinar again or see what previous Teach webinar, you're welcome to do so. But for now, thank you all so much for joining today and participating. We hope you all have a wonderful rest of your day.
Thanks, everyone. Thanks, Natalie. Bye.